Me okay? Okay, too loud, you can up, down. Yeah, okay. Well, that was a very nice introduction. I appreciate being here. It's always a privilege to speak before you guys, because you guys are always sort of the best critics and in a best position perhaps to evaluate the strengths and weaknesses of this kind of work. And in all fairness, I think a good disclaimer is that this is truly sort of fresh off the presses work, so we're still kind of working through the data, and I'll be actually really interested in getting your feedback today. So if everything works out properly, won't talk nearly as much as I usually do, and try to get you guys talking a little bit more. As a brief introduction, as Bill said, I've been working at the VA. I've been at the VA since 2000, and I've been in their Department of Informatics, and it's gone through a number of different iterations over the years, but currently it's been rebranded the Northwest Innovation Center. And for those of you that have been over there, I'm thrilled. And for those of you that haven't, I always welcome people to come over there, because we do a lot of operational and applied informatics. So it's an interesting complement to the types of work that you see over here. And within that department, we actually have been funded by the VA's National Center for Patient Safety since 2008-09. And the National Center for Patient Safety funds these Patient Safety Center of Inquiries. They're called PSCIs for short, which that's really a rather unfortunate title. Unlike a lot of traditional research grants where you're really trying to build on a foundational knowledge, this is more intended to be more of a research and more of a development and implementation kind of grant. So strictly speaking, we're charged with the responsibility of designing, evaluating, and disseminating tools that support an important patient safety challenge besetting the organization. In our particular case, there's a number of PSCIs, but in our particular case, it's medication reconciliation. And arguably, we could do it a whole lot better at the VA and probably nationwide. So the objectives for today, I'm going to be talking about a little bit about the RCT, but it requires a bit of a setup. Otherwise, it tends to be a little dry. And so first what I want to do is, these are the objectives I want to cover today. I want to talk about why I think reconciliation was a worthy focus of a lot of my career research activities over the last several years. And then I'm going to show how we tried to intersect a human factors approach in a human-computer interactions perspective on how we were going to do medication reconciliation, which I think distinguishes us or sets us apart from a lot of the other med-rec research activities I see out there in the United States, and many of them are very, very good. And then I'm going to introduce the technology that we had actually designed here in Portland, and then move into the evaluation life cycle, or at least that's the way I like to think of any sort of new technology, is that you have to go through this evolution or stages of the evaluative process that starts out from a proof of concept all the way through to whether or not it improves healthcare outcomes. And each step along the way, with the understanding that oftentimes the technology in and of itself is actually quite good, but the implementation is poor or not well tuned to the environment, and that actually is where you start to see problems that you need to tune or fix. Okay, so let's back up a little bit. Show of hands, how many of you are going to be again clinicians seeing patients? Okay, a fair number of the audience. Okay. And how many of you have actually been hospitalized or seen in clinic and your provider has asked about your medication list? Hopefully everybody. Okay. All right. So, at the VA, if you haven't worked at the VA or you're not a veteran, this is how it kind of works. It's a little bit like Kaiser. So it's a closed healthcare organization. So we manage the entire medication distribution supply chain. We have the medications. So what happens is you come in, I see you. I'm going to write an order for the medication in the electronic record. Then that prescription, and there's a timestamp on that. That prescription then goes to a pharmacist internal to my system. And they review it, and then they actually finish the order in our database. And then what they do is if the patient's right there, they'll actually dispense it out of our local dispensary. And if they're, say, out there in the wild, then they will kick out that prescription to a regional distribution center, a CMOP, centralized mail outpatient pharmacy. And imagine, if you will, I've actually been to one of these. There was one I actually went to in Tucson. Imagine something the size of a super Walmart, floor to ceiling. And as far as you can see, just racks going like 2-3 stories high of just drugs, tons of drugs, and these conveyor belts all over the place that are shuttling drugs all over. And they get they get, that one in Tucson, for example, they're doing medication dispensation from all over the West Coast, including Guam and Hawaii. And so they're getting this, and every single medication comes off the conveyor belt, and then it has to be reviewed by a pharmacist or a pharm tech. They have to open it up, look at it, confirm it against a picture, close it up, verify the address, and send it out, and they timestamp that, so that you actually have a timestamp all the way until the time that the patient gets it. So the only thing you don't have electronically is when the patient actually stuffs it into their mouth. So with that in mind, theoretically, since I have all the information in the supply chain, I should know what the patient's getting. So here's the question. This is the question that's fun to ask. What proportion, how often do you think that the medication list I see in CPRS, when I go and see a patient, how often is that an accurate reflection of what the patient's taking? This is the fun part. Throw out any number.
100% accurate?
I'm saying, what percentage of the time, no ringers, by the way. No ringers. What percentage of the time, knowing everything I just told you about the medication distribution and supply chain, we manage everything. What proportion of the time can I sit and look at the chart and go, yeah, well, I actually saw when it was mailed to this patient's been seen relatively recently, so what percentage of the time can I say this is what the patient's taking? And I'll even throw in a bonus, which is I attend on rounds with residents. And the most common thing the residents tell me is, we review the med list of the patient says he's taking it as written. It's the most common thing they tell me. So how often is that true? We actually know this. What percentage of the time? Anything. 40%. Okay. 75%, 10%. You guys are all over the map. Okay, so you guys are saying somewhere between 10% and 75%. Anybody want to go lower or higher? Lower. All right. Okay. Cool. Exciting. So this study was actually done by a friend of ours at Iowa City, VA. Yeah. Awesome, right? So it turns out that when they actually looked at the ambulatory med list and then brought the patient in for a gold standard or whatever you're going to call it, let's call it a reference standard because you're not really going to know unless you're doing observed pill consumption. It was 5.3% of the time. So we actually repeated that work here, and for our RCT, and I think we were somewhere around, Cass, like 3%, 2%? Yeah, about 3%, 2% of the time. Okay, so this is really important. I wanted to set this up because I told you, residents tell me all the time they're taking it as written. And if you believe in these sort of statistics, the probability that's true is exceedingly low. So you can operate off a heuristic and go, how often is the patient going to take the meds the way it's written in the chart? None, never, ever. So every time I see it written in the chart that they just drop in the med list, I know you don't have a good history. That's the heuristic. Now, sometimes it's true, but in general, it's not. And what's more, we also know that we're looking at somewhere in the neighborhood of 2 to 4 discrepancies per any clinical encounter. And I've seen as high as 8. So it really begs the question, first of all, what do we need to do in order to try to improve our diagnostic discrepancy our diagnostic capability to detect discrepancies? And the second thing it begs the question is does it matter? Because if nobody's been doing up until now and patients haven't been dropping dead like the apocalypse, did it make any difference? And this has actually been brought up to me before. Does it really matter? So does it really matter is a really interesting question. We have a colleague of ours, Kenneth Bookvar, he's an informatician. He works at the Bronx VA, and he's at Mount Sinai. And he actually does the same research we do, and arguably maybe even better. He's a phenomenal physician researcher. And he actually tried to figure out what's the association between the likelihood that you have a discrepancy and a downstream clinical event. And what we're trying to do here is build a case that all this effort that we're going to put into this makes some sort of difference. Okay, so what he found is that he looked at patients that were discharged from a Bronx VA to a nursing home where they actually could track all the medications even several months out because the nursing home had their dispensary in-house. And he could figure out how many discrepancies there were, how many of them are unintentional, and then he could look downstream and go, how many of them actually translated to a clinical event? And it was actually pretty low. Now, there were a lot of discrepancies that were intentional for obvious reasons. If a patient has heart failure and you're adjusting their diuretics. But for those unintentional ones, he found that actually they had a positive predictive value or positive predictive potential for an adverse drug event that's clinically meaningful. They have to have something, a symptom, a bump in their creatinine, something that changed their outcome in an adverse way. But they found actually the positive predictive value was actually quite low, somewhere about 0.003. Okay, all right. And then just for good measure, there was actually another study that was published by Kaushal with the Bates group, and Bates is arguably they've really put down some of the most seminal work in the impact of electronic health records on medication safety, and they found somewhere in the neighborhood of 0.006. So we'll split the difference. So let's say that each medication discrepancy has a positive predictive value of 0.0045 of having some clinically meaningful outcome. Now, I don't know about you, but I like thinking about the way we think about numbers, metacognition. And I don't know how to rationalize 0.0045. It just seems so small as to be negligible. And the only way I can think about it is the economies of scale. What would that translate to my organization? Would it matter in my organization? So I did the math. If you say that there's, on average, 2.5 discrepancies per case, and each one has a positive predictive value of 0.0045, and last year at my organization, we did 415,000 outpatient encounters. That would translate to about a little over 5,000 very real clinical events, preventable adverse events per year. And then if you calculate on estimate from Schneider's work, and there's a number of papers, there's Schneider, there's Bond, there's multiple, even Bates has an estimator of what you think the cost is of an adverse event. So I try to pick one for an ambulatory setting. What's the average cost of an adverse event, or annualized over a year, for an ADE in the outpatient setting? And if you took that and then you multiply that by what the number we have, you're looking at a potential savings annually of about $7 million in my organization. That's a number I can start to get my head around. Okay, so we're talking like more than a couple plane crashes of people a year that potentially could be avoided if we simply institute something that would be a standardized approach to delivering care. Okay, so what did we try and how well did it work? First, I want to talk about the classic model of MedRecon, because by the way, by now, in the year 2015, when I was starting to do these talks in 2007, 2008, MedRecon was kind of a hot buzzword. It started to tarnish a little bit. There's a little bit of patina on this because we've been talking about it for years, and arguably we haven't seen much substantive improvement in the way we do business. We're still doing the exact same thing we did 5 years ago. Hey, are you taking these meds? And the patient goes, I think so. And you're like, well, are you taking your hydrochloride? Is that the white pill? I'm not sure it's the white pill. It's this sort of constant exercise and frustration. So maybe part of the reason we have this exercise and frustration is it goes back to what is the model of MedRec. And I pulled this one from the Joint Commission. You could pull it from the Institute of Healthcare Improvement. But multiple different sites essentially say the same thing. They say it's a 4-step process where you collect a medication list from the patient, you compare it to your organizational documentation, you identify and resolve discrepancies, and then you furnish the patient with an updated list, and you document in your health record. Now, that sounds really good to promote a campaign because it's simple, straightforward, and it's 4 steps. However, I would argue it belies the inherent complexity of real healthcare. So for those of you that have managed healthcare, it's anything but normative, linear, easy to anticipate. Usually it's a train wreck. It's a controlled mess. So how about this? We started with a different approach, and I don't see Dave Dorr in the audience, but we did a lot of this sort of formative work with Dr. Dorr, where he said, well, let's at least argue for this, that maybe if it doesn't work like a linear thing, but instead it's a continuous and iterative cycle of data exchange between you and the patient. And each time is an opportunity to try to hopefully incrementally improve the information you're gathering. But at least you're doing it in some sort of patient-centered way. That was the way we envisioned it. And so it actually was Dave that had actually coined the terms receiver arm and effector arm. Because where are you going to focus your energies? Do you focus your energies on how we gather a history? Or do you focus your energies on how you resolve discrepancies? Or both? And so we actually focused upon the collection of the medication list. Because we still say to this day that the quality of your medication reconciliation effort can only be as good as the initial history that you collect when you meet the patient. And then we try to intersect that idea of, okay, what can we do to actually improve our ability as clinicians to gather data and improve the patient's ability, or at least their self-efficacy, to furnish us with a decent list. Because this if there's one take-home message I want you guys to get from this, is that I'm never necessarily indicting the ability of a patient to give us a medication list. I think of it the same way. It's been said to me that you are an expert in what you eat every day, and yet try to actually tell somebody, recount what you have as the inventory inside your refrigerator. It's virtually impossible to do. Or likewise, I actually just recently had to have my car repaired, and I'm a reasonably intelligent person, and I've been studying medicine and statistics and data for years, but when when the mechanic tells me about my car, as far as I know, it works on the shrieking souls of the damned. So we have to think about how we can actually improve or augment people to do their work better, and that includes the patient. This is the approach we took, and it's borrowed actually from Don Abedian and then revised by Pascal Carrion out of the University of Wisconsin at Madison. And what they said was, you need to think about any intervention you design with the intent to understand the culture, the user, the workflow, the perceptions of the individual, what they bring to the table, and then try to also consider how those formative elements affect the cascade of events that result in your health system's outcomes. And try to, if you consider it in those terms, you're better positioned actually to predict which variables you can actually augment or manipulate in order to get the outcomes of interest. So let's take a look at our technology and why we thought we were going slightly more human factors, taking a slightly more human factors approach. So we came up with this, I think many of you have seen this before, we came up with this device called AFID, the Automated Patient History Intake Device. And the premise was actually pretty straightforward. We wanted to collect a medication history, and we envisioned this mashup between the types of technologies that you see in the private sector and what we do in healthcare. In healthcare, we have the electronic information and record, but in the private sector, you can go to Home Depot and you can purchase things by yourself. You can go to the airport. You can check in for your flight. You can upgrade your legroom. You can buy additional oxygen for the fuselage, whatever you need to make your flying experience more entertaining or comfortable. So we thought of the same thing here. What if we actually introduce these same kinds of technologies in a healthcare setting and actually increase the ability of the patient to actually furnish us with a quality list? So four things really essentially there were four innovative ideas that we tried to incorporate into this that thought about workflow and patients. Number one, the patient normally sitting out in the waiting room blacking out teeth in the People magazine pictures. Why don't we have them doing something productive? Let's have them look at their medication list. So we're trying to use the effective encounter time. We're trying to use the encounter time more effectively. Two, by doing it, we're actually going to furnish them with all of the lists that we have through all of our databases. So that's actually pretty hard to do when you're talking about 157 and some odd distributed databases within our enterprise that don't communicate particularly well. So we're going to gather that automatically. Physicians can't do that particularly quickly. They can do it, but just not quickly. Then we're going to show them images of the pills. So if the patient goes, I'm not sure if I'm taking docusate, is it the reddish kind of one, like this one, you can say, yeah, that's the one. And then what we do is we actually capture that and automatically put it into the health record so it's all automated. Don't have to type any keystrokes. So hopefully it's going to actually gift wrap or package for the clinician the information they need. Now, this sounds great on paper, but the question was, could we do this in a proof of concept setting? Could we actually implement it in a real world setting? And was it actually going to make any sort of difference in terms of how we manage our patient population? And if you guys haven't seen this, I really like this kind of approach. This is shamelessly borrowed from Friedman, and he initially called this the Tower of Achievement. So Charles Friedman's called the Tower of Achievement. What he was trying to do was in a very brief sort of opinion piece in JAMIA, but it really resonated for me because the idea was that any informatics innovation goes through an evaluation life cycle. Now, ultimately, we don't build these widgets just to make ourselves feel happy. We hope that we're leaving our genetic imprint on a healthcare system, that we're improving the outcomes of our patients. So how do we know that, though? Well, you start with the proof of a theory, and the theory should be sound based upon prior evidence. And then you go through development, and you get a proof of concept. And then you test it in a clinic setting, and you say, could people even use it, or did it blow up? And then we go through the deployment. So what is it? And I try to draw on from people like try to pull in from like diffusion, like the diffusion of innovation theory. Like what types of variables influence people's perceptions, or Davis's technology adoption model. What influences their perceptions of a technology, and what's the probability that they're going to use it more effectively? because that's important to know whether or not it was actually used in a skillful and consistent way. And then we look at things like our quality indicators, our key quality indicators, or our outcomes of interest. And so that's what I wanted to sort of frame it for you, because that's what we're doing here. Moving to the ultimate, which is an RCT, which is actually looking at not the outcomes, but the surrogates for outcomes, discrepancy detection, and high-risk discrepancies in particular. So we started, and by the way, as you go through this, there's always going to be critics, and that's appropriate. So we did have many critics, and the first criticism that we heard was patients couldn't possibly do this. And we did exit interviews with many of our patients, and we found that in general, patients could, in fact, go through a series of web-controlled like buttons, look at their medications and say, yes, I'm taking, no, I'm not taking, or at the very least, I don't know. And I don't know is an opportunity to have a conversation. What we also found, though, and what I think is important about this slide and I want to draw your attention to, is we put it into production but with no expectations of use. We didn't actually levy any sort of you must use this or this must be the standardized workflow process. We let it happen naturally in the ecosystem. And we found that in primary care, they were only using about 55% of the time. In fact, more often than not, we were finding that if you actually try to engage a clerk in the process, the clerk would go, don't worry about that computer, I'll just come check you in. So we had a culture that wasn't really incentivizing, rewarding, or reinforcing the utilization of the technology. Is it because the technology's bad, or is it because something about the way we actually tried to integrate it? And that's what we were trying to find out. So first we started to look at, we did some cross-sectional studies. Well, maybe we're not getting any information. Maybe the information is not useful. So we started with the most complex clinic we could think of. We started with a chemotherapy infusion clinic. And the reason why we did it there was I wanted to find a location where we had complex patients, multiple comorbidities, a ton of medications. I mean, it's any wonder that the sheer volume of medications they're taking didn't interact in such a way that these patients glowed when they left the room. And then we made sure that they were actually being seen in multiple VA facilities. So we were actually the tertiary care referral facility. So I want to insert as many variables as possible that I know tend to undermine a clinician's ability to gather a medication list. And this is what we found. We found that when we actually had them use this technology, and then we went back and we reviewed the records in a cross-sectional way, we were finding that, indeed, we were finding quite a high number of discrepancies. Something on the order of about 3 to 4 discrepancies per case, about 4. And for those people that said, well, they're not the important ones, they're the colates or the multivitamin. Yeah, there's tons of those. But we also found some pretty critical ones. In fact, this one I always like to bring back because to this day I find it's a useful thing when I'm telling my colleagues, administrators, mid-level managers, why do it? Well, that 0.03 or the 3 potentially lethal discrepancies, those were all actually anticoagulants. So I actually saw a patient that was, he had a malignancy. He had metastatic disease to the brain. He had actually been supposedly bridged for a procedure, and he was normally on warfarin for AFib, and they bridged him to Lovenox. But they didn't manage to communicate effectively to bridge him off, and he was lost to follow-up. So this was a gentleman that had metastatic malignancy in the brain and was taking 2 full-dose anticoagulants, which, even if you're not in medicine, you can imagine 2 full-dose anticoagulants inadvertently in a person that has a propensity to bleed in the brain sounds like a really bad thing, and it really is. So we knew that we were actually finding real information here that would actually improve the quality of care delivery. But I was still sort of struggling with why were we not able to get primary care providers to use it. Specialty care, the medical subspecialties were actually doing the best. Nephrology, for example, was doing very, very well. ID clinic, for example, was also doing pretty well. But our primary care clinics, not so much. And so that's when we decided, well, before we move much farther, we need to understand what are the barriers, perceived or real. And this might inform the kinds of research we do from this point forward. So we set up a survey where we surveyed all of the primary care providers and residents in the ambulatory clinics. And what we want to know is we wanted to ask them about what was their perception of their environment of care, what was their perception of MedRecon, what was their perception of the tool that we were giving them, and then how frequently they used it and how skillfully they used it. And this is all, the reason I have this slide up here is, again, this is just briefly introducing the idea that we wanted to try to use literature to inform how we ask those questions so that we would move closer towards trying to better tune our application depending upon what we found. And there's so many things that, in theory, should influence our perceptions or our utilization of a tool. Your workflow, usability, the usefulness of the product. And so what we did is we went back and we looked at Davis's technology adoption model, which is still actually one of the most ubiquitous models both inside and outside of healthcare, but we looked at other ones as well, a number of these added variables, TAMs, as well as the FIT model that was produced by Amenworth, and we started to essentially synthesize it with a colleague of ours in New Jersey. We started to synthesize it into a model, what we call the effective technology use model, because what we want to know is which variables, a small parsimonious list of variables, which ones are most likely to actually correlate with your perceptions of the technology and the probability of consistent use. And we also wanted to know not just consistency of use, which people usually ask is how often you use it, but we want to know how you use MedRecon tools. Are you using it just to update your records? Are you using it to have a conversation with the patient? Or are you using it to actually engage other team members in some sort of reconciliation event, like, say, a pharmacist? This is just an excerpt, but this is what we started to learn. We started to learn that clinicians did, in general, on average, agree that they thought that the tool was useful and improved their efficiency. But we also found something very interesting, which is that a lot of the clinicians felt that they were ill-prepared or did not have the resources necessary to be particularly effective in the reconciliation effort. So it's kind of like what you always sort of expected. Clinicians are busy, they want to do the right thing, but oftentimes, and they have a general perception of what the right thing looks like, but when you ask them how you operationalize it in a care setting, they don't have time, the patient doesn't know what's going on, they don't have the resources, they're backed up, they're backed up on their treatment rooms, they don't have enough rooms, they don't have enough nursing support systems or pharmacy support systems, and that was kind of what we found here. So we found it improved reconciliation, and it seemed to be better than past systems, but clinical self-efficacy was poor. But we also heard something else, which is a lot of the clinicians felt that it took a lot of mental effort, and they weren't certain how accurate the information was in comparison to, say, a usual care or an interview. And that was one of the things that I'd heard a lot was, I don't mind that you have a technology out there, but it couldn't possibly be good as my interview. My interview is far superior. I heard that in the perioperative clinic from a couple of clinicians I really respect, and I think they probably take excellent interviews. So, but we were already at a point where we're starting to actually turn this into a national product, and we really realized that if we're going to start turning this into a national model, we have a huge responsibility to try to answer that question for our colleagues. How accurate is it? What are the diagnostic characteristics? So we are, in fact, moving to a national platform. The VA has adopted this model and is starting to re-engineer it for a enterprise-wide deployment. And it's going to look a little different. They're actually going to connect to our corporate data warehouse to gather information from multiple installations. As I said before, we have 157 facilities and 157 instances of the health record. So they are actually going to where all that data is archived and normalized in Austin. They're going to pull that information, match it up to pill images that are stored or procured by our CMOPs, which I told you about earlier, these large dispensary warehouses, so that we have a reference point when the patient checks in. And these are actual screenshots of what the device is going to look like. We just usability tested an iteration of it several weeks ago, and we're writing up a report on this. We actually worked with a group out of University of British Columbia at Victoria, Andre Kushnerek, trying to evaluate the human factors perspective and how patients either are able to use it or struggle with this technology. So now let's look at the diagnostic performance. So we've talked a little bit about what we developed. We talked about deployment and some of the challenges associated with deployment, a lot of it cultural or perceptual based in terms of why clinicians were or were not using it. And we started to look at whether or not it's actually able to detect discrepancies, which is a key quality indicator. But we didn't really have a sense of our diagnostic performance. And and comparing it to something that we feel is a reasonable standard, a gold standard. Okay. So we started again with a model. What are we really trying to do here? So imagine, if you will, that we're going to have two axes. On the x-axis, resources. So if I put in just a little bit of resources versus enormous amount of resources, and I want to think about how much accuracy, what return can I get on my investment? And we're going to assume along the top is truth. Truth is absolute, perfect, this is what the patient does on any given day. And we look back at the literature and we said, where do we think we exist using different kinds of resources on this hypothetical topology? So we know already the medical record. I already told you that, 3 to 5%. If you just look at the medical record and say, is that what I'm taking? The patient goes, yeah, I'm taking whatever's written in the chart. They say, I'm taking whatever's written in the chart. I'm taking whatever's in there. I think so. My wife fills my pillbox, anything. If you just accept that, we think you're probably about 5% of the time right. We know from patient interviews, from studies of patient interviews by Badowski and some other groups that were largely pharmacists, we know that we can get pretty good, but we know it's not perfect because we also know that when they compare to things like pill reviews, they're not as good as a pill review if you have all the medications in front of you. And they're also not truth because we also know that if you do home health visits, oftentimes you'll find other medications that the patient didn't report to you. Stockpiles, over-the-counters, herbals, whatever, bat guano, whatever you can possibly imagine, we found in their homes. So we think, and what we're trying to figure out is where does the patient review fit into that? I don't really believe that having the patient sit with a technology in the waiting room is really better than a structured patient interview with a clinician. But it's certainly better than simply looking at the chart. But where? This was our hypothesis. We think that if a patient reviews list, it's pretty good. And if we can do it in an automated or systematized way, that would be a substantial improvement. We also think that by using the technology, we could incrementally improve upon that. Why? Because we're getting more data, and we're also furnishing the patient with images. So the patient, instead of going, I think so, is that the white one, is that the yellow one, we can show it to them. And we set up our study like a diagnostic study. So we said we want to look at the sensitivity and specificity of our diagnostic instruments. So now we're thinking about this kiosk technology as a diagnosis tool. And we're going to say that looking for disease, quote unquote, is the discrepancy. Very simple premise. And we actually were going to look at two arms. We wanted to look at how do we do if we do paper, so just any systematized process, and then how much does it incrementally improve if we do it on the computer with the addition of multimedia. And this was how we designed the study. And this is actually something that we published with Dave Dorr. So what we did was we said, okay, we're going to take a group of patients, and all these patients are going to have at least a handful of medications, and they have to have at least one visit. Why visit? Well, because we need to make sure that we actually have some sort of medication list as a comparator. And then we're going to randomize them to one of two arms. We're going to either put them in a paper-based review where they sit down with a sheet of paper that's generated from this canonical list. So we're going to put together a list of medications from multiple VAs, including some recent expireds, because we knew from prior literature the patients are often taking expireds and discontinues. And we're going to compare it to if they sat down with a computer terminal. And then we're going to bring them into a room, and we're going to sit them down with a clinician. They have to bring all their pills with them, and the clinician is going to conduct a structured interview using a standard set of questions in a standard order, and the patient has to have all their medications with them. Now, here's the weird thing. Then we had to do a triangulation. Can anybody think about why? Because we ended up very quickly, we piloted this, and within one or two, I think, Cass, it was really quick, right? Within just a handful of patients just piloting this, we had a problem. Something went wrong, and we had to do a triangulation. So what do you think that was? Yeah. Human interface with the tech. Go on. So what do you think? What do you mean? You said human interface with the technology. Okay, so one possibility I heard is that, well, maybe we had to add another layer because there was something wrong. Somehow when we started interviewing the patient, we realized that things blew up with the technology. Anything else? This actually goes back to, I'll tell you, part of the problem was we just didn't see it coming. But part of this goes back to something that you're not supposed to violate when you do a randomized controlled trial. That's true. We definitely did. But I still wouldn't necessarily need to triangulate, would I? I mean, I have a gold standard. The history is my gold standard. Why do I have to go beyond? Interesting. So the patients actually, they were not blinded, so it's a single blinded study. I was actually one of the people that had to do the interviews along with several other clinicians. I couldn't tell. So what would happen is the patient would, I'll tell you, the patient would come into the room, and I'd do an interview. But here's the problem. Now I have a safety issue, because whatever they said before would potentially get to the record. And whatever I found could potentially be different than what they said. So I had to resolve those and pass them on to a clinician. This was in a real clinic. And what did we find? We found that sometimes my interview wasn't as good as the paper or the AFib. By the way, I didn't know what they were doing. They'd come in, and I'd interview them, and then I'd have to turn over the sheet of paper because we took all of their answers and we converted them to a paper report. So I couldn't figure out which patient did which arm. I just knew their answers. That's all I knew. But every time I'd get them, I'd look at the answers and I go, well, these answers, this is different than what I just interviewed, so let's go over it again. And what would the patients say? They go, no, that's what I really meant. I'm going, you meant what you reported before I talked to you? Yeah. You just didn't understand me, Dr. Lesselroth. So suddenly our gold standard was nothing more than 10, because what I'm starting to find is any information would actually improve the quality of the history. And when I confirmed this with the patient, when I'd actually checked the results, I found that oftentimes the interview wasn't that great either. So we had an additional comparator. I had an interview, but there wasn't a gold standard. So we decided, and this is a problem, because now your gold standard, if I actually go with the triangulation and figure out what they're really taking after 3 or 4 sources of information, the problem with the triangulation is you've just violated one of the standard principles of doing an RCT. Your gold standard should not be influenced by the results of the test. But here we had a conundrum, so we had to use both. An unusual situation that you'd kind of only really see in an informatics type thing. I haven't really seen this too often in other kinds of diagnostic tests, where everything essentially got flipped backwards, where we had to go, okay, we're going to compare each arm to our medication history. We know our medication history is no longer truly a gold standard. It's just an interview, nothing more. And then we're going to compare it to our reference standard, but we're going to keep both in the equation, because we want to see how we compare to the reference standard, and we want to see how we compare to the interview, recognizing that the reference standard is actually influenced by our interventions. And that was a toughie. So this is actually how we operationalized this concept. We were going to see how often the X, Y's, and Z's are discordance. So we were going to see how often our technology actually found discordant information compared to the EHR composite list. So how often did we get discrepancies, basically? And we also want to see how often each arm was concordant or discordant with both the interview and the reference standard. And if everything's working out the way we hoped it would, if you just sort of picture in your head, you're going to find a whole bunch of discrepancies. So this arm is going to start moving away from computer and closer to truth. And if we're really lucky, these 2 arms are going to move that direction at a different rate. That was the idea. So this was our enrollment. We powered it where we needed about 200 patients, and we wanted to power it at the patient level. We didn't power it at the discrepancy level, at the medication level, because we couldn't actually make any assumptions about independence. Each patient, each medication or each error actually is nested in the concept of the patient. So this is at the level of the patient. We had 614 appointments that we had a pool to work from. We were able to consent 220, and we actually got 209 that made it all the way through to the completion where we were able to look at their data. So starting with the descriptive statistics, what did we find? So, not surprisingly, our veterans are of a slightly older population than probably you would expect in a community practice. The average age is 66, 95% of them are male, and they had a high number of chronic medical illnesses. So comorbidities, 5.5 on average. We're talking about COPD, CHF, coronary disease, so forth. You'll notice, I think, the areas that I bolded, which I think are hard to sort of distinguish until I explain it, we looked at the number of medications and the number of active prescriptions. Medications for us also meant over-the-counters or medications that were expired but the patient was still taking. So we actually looked at a lot more total medications than active prescriptions that the patient was carrying on their medication list. But the average number of medications the patient carried on their list was 11.5. Arguably quite a bit higher than some of the studies that you'll see published on MedRecon, where it usually hovers around 4 or 5. Arguably, when do you think things start to get unsafe for a patient? How many medications do you need to start exponentially increasing the number of potential errors or drug-drug interactions? Anybody know? Somebody said 5, 7. Yeah, the number that's been published at least is 4. So that gives you an idea of the complexity or the risk burden that we're looking at with a veteran population. Then we actually looked at the discrepancies. So we looked at 3,500 medications, and we picked up 1,400 some odd discrepancies overall. Not great. And by discrepancies, again, I mean compared to our usual care, which is the health record system. And then when you break it into the two groups, now I will tell you that this stuff is really, really fresh, so I'm very much interested in your feedback. We literally received this from our statistician just within the past few weeks. And it's not terribly surprising, but a little bit alarming, in that we expected to see a lot of discrepancies, but maybe not quite this proportion. We did expect to see a lot of medium and high-risk discrepancies. Now, we actually coded all of these based upon previously published literature. And if you have to be a high risk or a lethal risk, you really have to be something like on an anticonvulsant, an anticoagulant, or an oncology agent, and specifically a chemotherapeutic oncology agent. And we actually found a not insignificant number of those, a lot of problems with, like, say, Coumadin, for example. And then high risk, it had to be a drug, to make it into the high risk category, it had to be a drug that's managing one of your chronic conditions, and that if there was a discrepancy, we envisioned that there would be a potential problem in terms of their illness management, like a beta blocker for somebody on heart disease, or a diuretic for somebody that's got heart failure. And again, we saw a relatively high proportion of high risk. Not a high proportion of lethal risk, but certainly not insignificant either. Oh, the other thing I want to draw your attention to is the system and patient. When I was doing this work, I was working with hospitalists, and some of the hospitalists said to me, they were very sympathetic. They said, "I really appreciate what you're doing, Blake, and I'm glad that you're making these efforts to try to improve our ability to gather information. But I don't really think it matters, because I've done this for 10 years. I remember one very clearly, one clinician saying, Blake, I've done this for 10 years, and it just doesn't matter. No matter how hard you work, the patients just can't keep it straight. It just doesn't matter." And obviously, I think it does matter, but I understand, and I'm sympathetic to the point that you start to get this sense of frustration that you're working with somebody that doesn't understand medications the way you do, and what can you do if essentially you release that patient back out into the wild, let the doves fly? What are you going to do? And so that's why we wanted to look at, well, how often at the time do we think that the root cause of this discrepancy would be based on something we did with our documentation? Either we didn't update the documentation, or we didn't listen to the patient, or we left something hanging out there that shouldn't have been hanging out there. And we found actually close to 50% of the time, I mean, it's almost half and half, that we're partially to blame in our healthcare organization's record-keeping strategies. And I thought that was important, because even if you could change patients at all, which I don't think it's a matter of changing them or not changing them, it's a matter of being patient-centered. But even if you held to that philosophy, there's so much that we can do on our side of the equation. Disagreement. Now, we're still cooking these numbers, meaning this stuff, we're still going to be looking at it for the next several months. And this is just the preliminary data. Spoiler alert, so far I'm not seeing that there's dramatic improvements in our technology. But looking at the EHR versus the instrument, I want to draw your attention really to the first one. We're seeing that we're finding discrepancies in both arms, our paper or the technology, and it doesn't appear to me that we're seeing more discrepancies or detecting more accurate discrepancies using technology. A little bit of a letdown, but I still think this is very interesting for a number of reasons that I'll get to. And remember what I said earlier about this was all about trying to figure out what's the diagnostic potential. And so all just went right back to it, grounds right back to this conversation I had with that clinician years ago that's going, nothing you do is as good as my interview. There's nothing you can do. Your technology, it's cute, it's gimmicky, but it's just not as good as what I do. And I always thought that was so interesting. How good is it? How good is the diagnostic performance? So using the standard 2x2 table that you guys have all seen, here's paper. The sensitivity and specificity compared to our reference standard. I use the triangulation one as our reference standard. And you could say I should have used the interview, but I decided to go with what I think is the closest approximation of truth. About 90% sensitivity specificity. Not bad. Not bad. Here's the technology. Numbers didn't shift much. About the same. In fact, maybe the sensitivity is actually worse. Now, arguably, I don't think this is going to be a statistically significant difference, but still, a little bit surprising. For all the technology, could we have just done paper? And actually, we just did paper reliably. That's pretty good. I think it's better, actually, than what I expected. So, what's going on here? Well, remember this slide? Accuracy versus resources. And this is what I said I think is going on. It's pretty early, but I don't think this is what's going on. I think it's more like this. I think still, if you say you're looking at the medical record and going, is this what you're taking, Mr. Jones? Mr. Jones goes, yeah, I'm taking whatever it says in there. I take whatever they say in there. Just check with my wife. I think you're still hosed. I absolutely think you're hosed. But what's interesting is, and we definitely know that when you do a patient interview and then you gather more information, things change, stuff moves. Now, we're not the first ones to report that, but I still think that at that top end of the curve, it's probably somewhere in that ballpark. But now I know that patient lists and technology seem to be pretty close to each other, almost equifinal, but better than I thought. Maybe within 90%, 85, 95% of accuracy. Enough that you shouldn't be interviewing the patient? No, of course not. But perhaps enough that you can start to recalibrate how you think about medication discrepancies and better target where you're going to focus your energies as a busy, overworked, under-resourced clinician. So this is what we've... Actually, I want to back up. So just out of curiosity, because I don't know. I mean, I'm making it up as I go. Why do you guys think the technology didn't work better? Okay, so one argument is you're getting the same information. You're getting the same information from the same source. You just did it in a slightly different way. You set down a different backing track. That's it. What else?
And by the way, if I can ask people to push the buttons and the microphones in front of them so it gets picked up by our recording, and so people listening can hear it. But the real intervention is the sort of sitting down with the patient and going through the medications. So, that intervention may be overwhelming any potential benefit of any kind of technology that you've added. Okay, so that's certainly plausible. Where we've really set up a pretty oddball-y usual care and gold standard. I mean, our gold standard is a little more gold than your typical, and our usual care, even the paper, we're pulling from a lot of different resources that you would normally have in the context of real care. So that's, it's possible, like Dr. Hirsch is saying, was the study design, arguably we tried to set up to be as rigorous as possible to detect nuanced changes, but maybe it just simply diluted our treatment effect. You had a suggestion.
Yeah, so maybe it's somehow your effectiveness is somehow getting washed out by kind of a broad application of what you want to do. And I think you kind of mentioned this, that maybe a more directed approach might give you a little more efficacy. And somehow there's some data washing going on just with the broad population implementation.
I like it. I think these are all and I wanted to hear what you guys say because these are some of the ideas that we came up with, and none of them necessarily are correct, but one is we were just so darn overwhelmed. I mean, when you're talking about patients with like 12, 16, I saw a patient with 50 meds. 50 meds. I mean, that's insane. I can't believe this guy's head didn't explode. So is it possible that you just simply completely overwhelm their cognitive faculties? I mean, that's like asking me to try to describe how to rebuild an engine, and I don't know anything about a car. So maybe that's it. Maybe it's just too many round white pills. Celexa looks a lot like aspirin, which looks a lot like, a salt tablet. They all look white, round, and scored. So maybe Images isn't doing it. Maybe it's the control design. It's like a couple of you guys said, is we coned big, and we had a very unusual set of control versus maybe it's a lot better than usual care, but our control is hardly what you call usual care anymore. The other thing that kind of was interesting to me is we thought about whether or not it's a computer. We were actually even talking about this as recently as this morning. Does computers actually make things worse? Now, I thought we were putting in pictures, and pictures are great. But maybe when you sit a person down in front of a workstation and the font's different, and the experience is different, maybe that difference is a confounder. And then I put up this graphic because I thought this was pretty interesting too, is that we all believe, and there's some reasonably good data to support this, that there's something called the pictorial superiority effect. We remember experiences actually the most. If you experience something, it actually tends to forge better long-term episodic or semantic memories. But in lieu of that, showing people pictures or objects, interacting with objects, pictures, something visual, in general, tends to actually forge better long-term durable memory. But that actually seems to go down as you get older. And it appears that sometimes the pictorial superiority effect starts to go away or converge with other ways we encode memory as we get older. So maybe even that's it. So in conclusion, and hopefully I'm a little bit longer than I wanted to go, but in conclusion, what I wanted to share with you is that I'm excited, a little humbled, but nonetheless excited to share with you the very, very newest data that we have on our study, which I think there's some things that I can say that I think are good. We can say that by intervening in a systematized way, we can dramatically improve our ability to detect discrepancies above what I frequently see done as an ad hoc process within my own facility. I think by using technologies in the right way, in a human factors way, where we try to actually optimize the time that the clinicians have available, I think we can actually augment human-based performance. We're not trying to replace an interview. Replacing an interview is the wrong way to go. It's the unified theorem of informatics. You guys all know it. It still holds true here. High-tech and low-tech solutions may be equifinal. In fact, if I could get 90% accuracy by just sitting them down with a sheet of paper, that's a great place to start. And so I would actually suggest that for those people that say that med recon is too much, cost prohibitive, can't get done, which I hear all the time, start low, start lean. And you probably can get a lot of return on your investment with a reasonably small investment. I think the investment is really in the organization and the culture as much as it is with anything you do technology-wise. And you have to commit to that standardized process. It has to be rewarded, reinforced, and barriers to using that process have to be removed. It has to be done, I think, at a level higher than one clinician or one researcher. It has to be an organizational commitment, a value system, an ethos. And then finally, I think we're finding an awful lot of high-risk discrepancies, more than I anticipated. And I think more than we realistically can handle with our current systems, our current effector arm, as Dave had called it. And I think if we're going to move in a more systematized way to solve these kinds of problems, we also need to expect that we're going to need to resource our clinics and our hospitals accordingly so that we have better self-efficacy, the thing that clinicians told us way back was a problem. I'll stop there, and I'll leave these up here since I know this is going to be, I think, posted for later. But I do I appreciate your time. I appreciate Bill asking me to talk. It's always a pleasure to present before you all because you guys represent really an interesting niche set of experts. And so I appreciate your time and your interest, and I would love to hear any other questions, concerns, comments, or criticisms you have because you're coming at the right time. I'm also open to criticisms because it's early and more work can be done. But thank you. That's a great question. Yeah. So, and I think that's an important point, is that we do know that the patients often will not actually completely disclose information to you. I struggle with this all the time. Patients don't want to disappoint me, or they don't want to appear that they're anything less than thoughtful and principled in the way they approach their health care. And so that was part of this triangulation exercise, is if we're getting something wildly discordant between when they sit in the room with me and I flip over, I take the interview and then I flip over the sheet of paper, I'm like, this looks big difference. Let's go back. That was our goal, is to try to essentially, one, look at where those differences arose from, how, and negotiate them in a relatively, I think, in a blame-free environment. I say relatively because it's still an interview room, we're still wearing a white coat, and that still imposes a certain hierarchy that can be problematic. I think that's an important point to make, that we tried to minimize that effect. Whether it went away completely, probably not. Would there be another way to do it? Possibly. Maybe even better without a clinician, but for this particular set of circumstances, we really wanted people that had clinical prescribing capability, that subject matter expertise. Other questions? Yes.
But did you look at the effect of having either the paper or the technology before the interview, like as opposed to just having an interview? Is there some potential benefit of having some sort of activity beforehand that helps jog the memory that's going to affect how effective your interview is?
I see. Interesting. So what you're saying is, what if you did the arms different ways and you said, I'm going to have one interview and I'm going to have one primed interview? Yeah, no, we definitely didn't do that, but that's an interesting theory, is the use of, because we do know, I think you bring up an important point, which is what we're starting to see is, and again, we're not the first people to show it, it's just we're finding something that seems to be triangulating with other people's research, which is if you use multiple channels and multiple ways, you seem to get a more holistic or representative model of the truth. 2 interviews back-to-back, spaced by about a half hour, seem to change your history. I love to do this to residents. It's called historical drift. The crushing chest pain in the morning invariably becomes right lower quadrant pain by the afternoon. That's how you can disgrace any intern immediately. But the thing is that it's definitely true with this. So I think you bring up an important point, which is, what did we do through the priming experience? We don't know. This obviously wasn't set up for that. But it would be an interesting argument to say, I think technology is important. I think technology is even important for a pill clinic. Why? Because I think the priming may do something that actually positions the PharmD, the clinical pharmacist, to have a more successful or robust clinic experience. It's a good point. We didn't test for that. Yes?
I was considering the possibility of prepping the patient before they ever came into the clinic. Maybe delivering via web portal to have them audit their medications at that time before they ever came into the clinic with information. I thought it might help with recall because they're in their controlled resource for where they're going to take their pills and integrate it into their daily lives instead of being in a clinical situation.
Yeah, and that's an excellent point. So this point about what can we do to actually, asking a patient, again, to recall the contents of their refrigerator when they show up in clinic seems dreadfully unfair, actually. So what could we do to actually prime the patient so that they are in a better position to be prepped for clinic? That's an excellent point, and actually that is something that we've been helping another group do. So Dr. Stephen Simon, who's actually at he's faculty at Harvard, and he's the section chief of general medicine at the Boston VA, is doing the exact same thing we're doing, only he's trying to do it over the My Healthy Vet web portal. So what would happen if the patient actually had this same kind of information, a multimedia list of medications with images, but delivered into their home environment over a computer? I think absolutely anything we can do. Now, arguably what you've seen today could say, could I have done something similar with a card or a phone call? Maybe. Does it have to be a web portal? Why is that important? Well, one, because it's possible that the technology also introduces a new confounder that makes it more challenging. And two, the number of patients in the VA population that we've actually authenticated for doing that type of health record through the home is reasonably low. Now, the numbers are going up. Kim Nazi has been publishing on this in JAMIA, and the numbers are going up. But in general, it's still a smaller fraction of the population because, again, our population is older. They often don't have computers. I've met veterans that when you say pick up a mouse, They look at the table and they're like, I don't know what you're talking about, because this clearly doesn't look like a mouse. You see what I'm saying? A lot of our patients don't use an ATM. So, so these are barriers that I think will change as the demographics of our population changes. But that very thing that you're pointing to, it is being done, and actually there has been some preliminary research published by Steve Simon's group, and I believe the lead author is Hayworth in JAMIA, Leonie Hayworth, who was his PhD candidate. Yes, another question.
Of those 200 some odd veterans that you looked at, I'm curious as to another question. Well, how many of them go to the same pharmacy for all of their prescriptions? And is there any way that we can make use of that to improve our accuracy?
Go to the same pharmacy for the prescription. So, okay. Yeah, I don't, for those, so what was the, let's see, so taking a step back, Cass, can you recall, on average, what was the average number of non-VA medications that the patients were taking? Was it per around 20%? Okay, so 20%. Okay, so on average, 20% of the medications that we were reviewing were medications that were procured from outside the agency. And that, of course, they can get from anywhere, over-the-counters, their aunt's medicine cabinet, whatever, you know, maybe they're taking their veterinary meds, I don't know. So for those patients, yeah, we have no way to actually link to those pharmaceutical repositories. It is starting to be done. Ken Bookvar, the gentleman I was talking about at the Bronx VA, he's actually piloting a Rio where they actually have a network of people that are doing pharmaceutical data exchanges in that New York borough. And they are just starting to get some preliminary data on how they actually may augment or improve the residents' ability to collect a history and validate a history when a patient's admitted to the hospital. But at least for our patients, we didn't look at actually where their pharmacies, where they were procuring from. But then on the flip side, 80% of them are getting them from us. So, and we know exactly what they're getting. They're getting them all from that same dispensary. Yeah, James.
Maybe one more question. A related question. Is the SureScripts database accessible by VA clinicians?
No. Well, not yet. I mean, unfortunately, so we're still trying to broker the data exchange agreements, and that has to be done not at the facility level, not at the provincial level, but at the national level. It may be in some pilot sites. I know as for our site, I can get access only to the data from other VAs through essentially an exchange that's an exchange within the VISTA database that was written for precisely that purpose. We also can get some information from Kaiser. We get basically a stripped or static health summary exchange from Kaiser as part of a piloting experience. There have been other pilots. There are pilots with DoD. There may be pilots with SureScripts. There's definitely the Rio. There's a couple Rios that are done, but in terms of ubiquitous or standardized way to do it, no, absolutely not. And that's a huge problem because, again, the VA, I think James brings a good point to the surface, which is the VA arguably has more leverage in their court as a federal organization, and yet we haven't done a lot in that arena to try to actually standardize, normalize, or exchange data with all of our community partners, OHSU, for example. Okay, well, thank you so much for your time. I really appreciate it. It was a pleasure, and
Stick around for a few minutes if you'd like other.
I stick around, and you guys can always get in touch with me. We're just a sky bridge away.